Thank you very much, Dr. Rena, for your kind introduction. And yes, สวัสดีค่ะ Professor Prapan. I didn't meet him in Bangkok, so it's a pleasure to meet with him in person. And I would like to thank the organizer for giving me this opportunity to speak. And my today's topic is actually around the role of the community engagement in patient care. And you may have thought about what I'm going to present, because I've been to many presentations, but there will be one slide that I will always use it, and I will never delete it from my presentation, and you will see which one. So, but I change my dress every day, right? And the room is quite dark, so not everyone might not be able to see me clearly, but don't get fall sleepy, right? So let's focus on the presentation, and there's many things that I would like to relate to Professor Prapan Phanupak's contribution as well. And my outlines of the outline of my presentation will mainly be talking around the key population-led health services in Thailand, or KPLHS, and I will share with you about the journey, the challenges, and the contribution around how are we going to make an effort to institutionalize the KPLHS in Thailand. And I will end my presentation with a few key takeaway messages. So this is the pictures showing the key population-led health services journey in Thailand. Starting from your left-hand side, you can see that like many other countries in Asia, Thailand was also, the community's role was quite limited in HIV responses. We started our role by working around outreach activities, right? We had to go to the hotspot to conduct an educational session, to provide educational material, to demonstrate how to wear condoms and to use lubricants appropriately. However, in 2011, there's some community-based organizations in Thailand that thought why can't we provide HIV services at our organization? So there were nurses and medical technologists were invited to conduct HIV testing at the community-based organization. And then later in 2015, Dr. Nitya and Professor Prapan got asked by a few of the community representatives asking about would it be possible? Is that really difficult for a community person to conduct HIV testing? And then I think it has actually led Professor Prapan and Dr. Nitya to come up with a small implementation study on the first key population-led HIV test and treat. Under that implementation study, there's one important component that allow key population-led providers, which coming from men who have sex with men, trans women, sex workers, to be trained and to be strengthened their capacity. And under this study, they were trained and allowed to conduct finger prick blood collection for HIV testing. They were able to do the STI sample collection for chlamydia and gonorrhea. And they also allowed to dispense PrEP and PEP with the medical supervision. And then the data from these key population-led test and treat services is really showing that if the community's members are trained and certified, they would be able to do some level of the clinical services in the HIV programming. And then a year later, PrEP was introduced for many years already at that time. But we thought that, so the community are able to provide HIV services and HIV testing, why don't they can do PrEP dispensing at the community's clinic? And then at that time, we did not have PrEP medicine. We did not have any money to do the laboratory testing. Professor Prapan came to me and asked me, Rena, oops, sorry. Can you develop a few pages of the concept sheet? Because I'm going to get the money from Princess Somsawali. And then the next day he came to me Rena, can you finish that? I said, yeah. He normally start working at 6:30. And I normally arrive at 6:30, but I'm not going to start working yet. I'm going to wear my makeup and have breakfast first. And then I finished, and then he revised the document. And then I think a few days later, we heard that, the Princess Somsawali's fund that primarily aimed to use for mother-to-child transmission funding has been underspent, and this will be converted for us to purchase the PrEP medicine from the government pharmaceutical companies. And for the lab course, we were supported under the FHI 360 project through the USAID as well. So at that time, we were also able to demonstrate the power of the community-led organization to be able to serve and to reach their community members. I think we have been using this kind of evidence-based data and information to create national dialogues and to advocate for policy change with the Ministry of Public Health and the National Health Security Office until 2019. According to the Ministry of Public Health ministerial regulation, they finally allow trained and certified key populations lay provider to perform some certain of clinical services, which include HIV testing by finger prick blood collection, STI sampling collection, PrEP and PEP dispensing, as well as STI oral treatment medicine as prescribed by physicians. And it's really showing that the journey of the key population-led health services in Thailand was not that easy. But I think through Dr. Prapan's leadership and vision, I think we can make it possible. And this slide shows you about one of the success story from Thailand. You can see on this slide that 82% of the current Thai PrEP users actually coming from the 11 key population-led clinics in the countries. However, when comparing with the national PrEP target in Thailand, we have only achieved 22% when against with the national PrEP target in the countries. So there's an urgent need to accelerate, to scale up and expand the key population-led health service model throughout the countries. And then in June last year, Thailand, my country, we were commended by the UNAIDS Executive Director about how the key population-led health services were ensured in terms of sustainability and financing mechanism to allow key population-led health services to perform their work at the community. But 6 months later, in December last year, I don't know if you have heard about this story, right? In December last year, we had the Ministry of Public Health actually denounced the key population-led health services to dispense PrEP at their KP-led clinics. And under this ministerial regulation, is also required the key population-led clinics to surrender their PrEP dispensing authority to the public health facilities. As a result, thousands of current and new PrEP users will now have to go to get PrEP at the hospital according to their registered health scheme, no matter the distance or the cost. So it's really showing that right now we have been experiencing with the PrEP service disruption in the countries. And I understand that if there's any representative from the Ministry of Public Health in Thailand, I know that we have been working together to try to solve and address these solutions. However, we really want something like this to be more sustainable. And my presentation showing the community's role in HIV prevention cascade. However, the community's role can be expanded to the HIV treatment cascade as well. In this slide, I would like to share with you about the data from the community-led same-day antiretroviral treatment, or the community-led same-day ART that I previously presented with you yesterday. You can see that once the community members, they were trained, they were certified, and they were empowered to bring the treatment to the community or to their friends, I think it's possible. On your right-hand side, you can see that almost 90% of those who diagnosed with HIV at the community-led clinic, they are clinically eligible to get the ART on the same day of the diagnosis by the trained peers, counselors, with the support from the physicians who are working remotely and doing the telehealth platform service supervision. And yeah, these slides that I always use in my presentation, it doesn't mean that I'm lazy, I'm not revising my slide, but one of the key population-led health service model that I'm very proud of is the Tangerine Clinic. And, you know, when I worked at the Thai Red Cross, one day, Dr. Prapan came to me and sat next to me and asking, Rena, can you tell me how MSM and transgender women, why they are different? I thought they are the same, right? And he said, listen, Ajahn means teacher, no? Like, listen, professor, we are different because we have, okay, we might have the same sexual orientation, but we have different gender identity. And he did not understand that, I'm sure. And he was like, his face was questioning, right? So I said, I was born male at birth with my male organ, but my gender identity is a woman. And do you think that I'm a man or I'm a woman? He said, a woman. Yes, so that's why and it's led him to revise the work that he has been doing before. He said like, oh, I opened an MSM clinic, but I did not see any transgender people coming for HIV testing at all. And he said, of course, if I work, you know, like, I am the one probably wouldn't want to come for the MSM clinic because the services was not well tailored to my needs, to my specific needs. And we need to do something. We need our own space, we need our own staff, and we need our own specific healthcare services. He said, okay, let's do it next week. I said, no, please wait. You know, that's why Professor Peter told me that he makes everything like happening very quickly. I said like, let's consult with the transgender community first. I can't represent all the transgender community. So it came to the day that we organized the first transgender community consultation in the country. Dr. Nitya and Professor Prapan, they were there, sitting with the transgender community all day long, listening to the needs, listening to what kind of services we wanted, listening to the transgender community. They were arguing about what should be the name of our first transgender-led clinic. And finally, we came up with the conclusion and the consensus that, okay, we should go for the Tangerine. It's not too feminine, it's not too masculine, and it's kind of orangey and, you know, appetizing as well, orange. Look at me, huh? So, and I think in November, so before we opened the clinic, we also conducted a gender sensitization training to all healthcare providers at all levels. It did not only include the physician, but it also included the security guard at the entrance, the receptionist, medical technologists, pharmacists, counselors, everywhere. And Dr. Prapan kindly attended gender sensitization training with me as well. And I was training him on that. You know, like what are the SOGI mean, sexual orientation, gender identity, sexual and sex characteristic, and gender expression. It must be confusing for him as well, but at least he had intention to learn and better understand more about what the community really wanted. And in November 2015, we successfully opening the Tangerine Clinic, no? At that time, we were located at the Thai Red Cross, and he kindly gave us this blessing. On your right-hand side, you can see this is the blessing that my staff at the Tangerine Clinic, we always take it as the core principle of when we are both providing services and when we are conducting the research concerning about transgender populations. So I will use this slide wherever I go, but the team, my pictures that I'm sitting in the middle might be changed, from time to time, but yeah, this picture will remain. And later, I think like, we cannot only focus on HIV and gender-affirming care. There's other emerging health priorities coming from the communities. We listened to the communities and we found that one of the challenging issues, especially during COVID-19, is about mental health. And we had an opportunity to receive a grant to conduct an implementation study around mental health service integration. And this mental health service integration has been led by a trained transgender person who are working at the Tangerine Clinic. And here are the preliminary data from the Chimera D43 project that's proving that a transgender-led depression screening is feasible and to be able to integrate as part of the comprehensive healthcare service package providing for transgender populations. And I think another pride that we would like to share with you is about the Tangerine Clinic has been established for 7 years now. And we have received interest, we have been receive many participants or researchers or providers coming to learn with us at the Tangerine Clinic. So that's why we established the Tangerine Academy as a regional technical assistant platform to strengthen the capacity of healthcare providers and community health workers in the region. And we had an opportunity to receive the funding from USAID to conduct, cross-country learning and technical assistance activities. And we have worked closely with these civil society organizations where they see that transgender competent care in HIV services is also important in their own settings as well. And this is a slide shared by Dr. Nini Tun from Medical Action Myanmar. She actually reached out to us and she was very interested to do this kind of stuff like the Tangerine Clinic, but bring it back to Myanmar, her country. And when we conducted technical assistant training through online platform, mainly because it was happening during the COVID-19 pandemic. And finally, she shared with us this data. I think this was very impressive. I think the data might not be a lot, but I think we can see the efforts, the dedication that Dr. Nini and her team is trying to make it happening. They were able to establish the transgender clinic called DAISY through our technical assistance support. And this data showing the HIV cascade among the transgender women who attended and received the services at this clinic. Those who were diagnosed with HIV, they are able to link 100% of them to ART initiation. And 60%, those who without HIV, they were receiving PrEP as well. So, however, when I'm talking about these kind of key population-led health services in a positive way, there are some challenges for us to address or to overcome. KPLHS is not only challenging in our region, but throughout the world. This is the data from the UNAIDS. On your right-hand side, you can see that in 46 countries, there are some restrictions that requiring that HIV services can be only provided in healthcare facilities. And in 66 countries, there's a lack of social contracting and other financing mechanisms to allow funding of community-led service delivery from domestic financing mechanism. And in 22 countries in the world, there's overly restrictive criteria for eligibility for community-based service delivery to perform the HIV services. So I would like to share with you that if we are not trying to overcome these challenges, we wouldn't be able to accelerate an end to the AIDS epidemic in our region or in the world. And I would like to end my presentation with these three key messages. I think we need to shift the paradigm from the community engagement to the community leadership. We have to value their power. We have to equally treat them as part of the national healthcare system. They are able to do task shifting or task sharing and to be able to reach out to the population that we cannot reach. Second, the key population-led health services can potentially be adapted to address other health priorities. For example, we are having the long-acting cabotegravir that we would want to explore how these will be conducted at the key population-led health services, viral hepatitis C or substance uses. This is something that the community can play an important role to address these health priorities. And lastly, domestic financing and enabling legal and policy environment must be made available in order to sustain the community-led and community-owned response to HIV. And I would like to acknowledge the support from the funders, development partners, civil society organizations, and these colleagues who have been listed here for having made the key population-led health services in Thailand possible. And because in June is the Pride Month, and my personal advocacy message is I would like to advocate with you all that the right to health of the transgender population and other vulnerable population need to be addressed in your country. And thank you very much for listening. Thank you.